I want to start with a problem we currently have that the outcome measures in randomized clinical trials aren't used in clinical practice and they really don't reflect the goals we have in clinical practice. The most common one you'll see used is the SRI or the Systemic Lupus Responder Index. That usually is a 4-point reduction in the SLE Disease Activity Index. Of course, we all want the manifestations of lupus to be less active, but that's insufficient in the clinic where we also want patients to be able to reduce their prednisone. BICLA is just a variation on the SRI where the major focus is on a reduction in the BILAG disease activity index. We're moving to organ-specific measures. 90% of lupus is skin or joints, so it won't surprise you that the CLASI, which measures skin involvement, and the tender and joint count are important. Now, I want to emphasize that we have to reduce prednisone if we're going to have our patients do well. This is a longitudinal study that we did that showed if the maintenance dose of prednisone is above 6 milligrams, there's a 50% increase in permanent organ damage. And you can see over a twofold increase in permanent organ damage when doses are above 18 milligrams. So our goal in clinical trials should be the very same goal that we have in our clinical practice, which is to keep the maintenance prednisone dose below 6 milligrams. Now, when we talk about organ damage, the most common organ damage is going to be osteoporotic fractures, followed by cataracts. And of course, people don't die usually of osteoporotic fractures, but yes, with hip fractures sometimes. And people don't die from cataracts. The major cause of death in lupus turns out to be cardiovascular events. And it turns out that prednisone is a direct factor in cardiovascular events as well. And here on this slide, you see the very strong dose response. So if the prednisone dose is 10 to 19 milligrams, there's a twofold increase in cardiovascular events. And if it's 20 or above, there's over a fivefold increase. Now, in modeling, we adjusted for all the traditional cardiovascular risk factors, and we also adjusted for the disease activity for which the prednisone was prescribed. So this shows you how all-pervasive the damage from prednisone really is, and it is contributing to the major cause of death. Now, where should we go? Well, obviously, in a perfect world, we would want to have our outcome measure in both clinical trials and in our practice be remission. And in fact, the Doris group has come up with definitions for remission. And there can be a remission or there can be a remission on treatment. Regardless, it requires that the prednisone dose either be 0 or 5 milligrams or less. Immunosuppressive drugs are allowed and hydroxychloroquine is allowed. Serologies do not have to normalize because I think everyone recognizes it's almost impossible to correct low complement and anti-DNA in everyone. Now, our problem is that the remission, even though it's our wish list, is not actually achievable. And I wanted to show you how hard it is to get to remission if your patient starts out at baseline requiring a lot of treatment. We're talking about years to try to achieve a remission. That's not practical in clinical trials, is it? Where the clinical trial will only last for 12 months. But it's also unrealistic in our practice where we and the patient want to have a realistic goal. We do know the patients who are highly unlikely to ever achieve a remission. In my practice, it is my African American patients, but it's also patients who start out with active serologies or patients who start out with hematologic lupus like hemolytic anemia or thrombocytopenia. So those are patients who are going to be much more difficult to treat and much more difficult to achieve remission.